morning. I've been asked to share some information regarding hormone replacement therapy, or hormones, in cancer. And when I think about this topic, I divide it into three categories: hormones that can cause cancer, hormones that can prevent cancer, and hormones that can treat cancer. I want to start with hormones that cause cancer. For women who are postmenopausal, the prompting to consider hormone replacement therapy is both vasomotor symptoms, which can be incredibly annoying, as well as osteoporosis prevention. The Women's Health Initiative, which was their first publication was in 2002, looked at estrogen and progesterone treatment together in postmenopausal women, specifically women that had not had a hysterectomy, so the need for progesterone with the estrogen was real, and I'll get to that in a minute. And what this study showed is that women increase their risk of breast cancer, coronary artery disease, stroke, and thromboembolic complications when they take estrogen and progesterone. A subsequent study from the same organization looking at estrogen alone in women who had had hysterectomies revealed that the side effects were not nearly as noteworthy. Specifically, the only thing that was increased was the increase in thromboembolic events. So that changed the landscape of hormone replacement therapy for a good bit of time. During the next 10 to 12 years, sub-analyses, meaning further studies, were performed on that same patient population. And what has been established is that women who are less than 60 years of age, or within 10 years of their last menstrual cycle, can take hormone replacement therapy with much less risk than what was first described in the initial Women's Health Initiative study. So the summary statement is really hormone replacement therapy needs to be individualized, and the risk-benefit ratio has to be carefully considered by any patient with the help of their physician. The other consideration when thinking about hormones that cause cancer is estrogen alone in women that have a uterus in place, meaning they haven't had a hysterectomy. We know that in that situation, if a woman takes estrogen alone, her risk of endometrial cancer goes up very significantly. So while estrogen and progesterone together increase the risk of breast cancer, estrogen alone increases the risk of endometrial cancer in a woman who hasn't had a hysterectomy. And there's many ways to address that as a physician, but again, important to consider individualized care and the risk-benefit ratio. Preventing cancers with hormones is not a new concept. Women at high risk for developing breast cancer, either based on their family history or genetic testing, can take selective estrogen receptor modulators and or aromatase inhibitors to prevent the development of breast cancer. And it has been proven in this certain patient population to be very effective. In terms of GYN malignancies, ovarian cancer, the incidence can be dropped considerably by taking birth control pills over a number of years. Again, a great prevention strategy, and in this case for a disease that has a high mortality rate. The other important consideration is we know there's a subset of women that are at higher risk for endometrial cancer. And for those women, either a progesterone IUD or cyclic progesterone can decrease their risk of developing endometrial cancer. There are other examples, but important again to think about this in the context of working with your primary care doctor or your gynecologist to prevent any or all types of malignancies. In terms of hormones treating cancers, breast cancer is the type of cancer that's been treated for the greatest number of years with hormones, either by selective estrogen receptor modulators or aromatase inhibitors. And there's a lot of data to show that in certain patient populations this is very effective. And similarly with endometrial cancer, the standard of care for a woman with endometrial cancer is a hysterectomy. However, if a patient is young and wants to consider maintaining fertility, there are select patients that can be treated with progesterones to maintain future fertility. That takes a tremendous amount of consultation, again considering the risk-benefit ratio.